Hello, I'd like to warmly welcome you to this session. My name is Phyllis Nakujeke, and I'm doing this presentation on behalf of my team, made up of researchers from the University of Ghana School of Public Health, as well as Ghana Health Service. The title of our presentation is Transitioning LLIN Distribution Campaign in Ghanaian Communities through Social Mobilization and Capacity Building. The aim of our project is to improve the effectiveness of the mass LLIN distribution campaigns by transitioning into the community-based health planning and services program in Ghana. And for this poster, we hope to present the process and results of our co-created intervention as we focus on social mobilization and capacity building of community health officers, in short, CHOs. Ultimately, we are hoping to increase the use of LLINs within households in the communities that we studied and also improve campaign effectiveness in Ghana. For this study, we selected a total of 6 districts, and I would like to mention at this point that these districts regarding malaria prevalence are very high. These were selected across 2 regions in the southern part of Ghana, that is the eastern region and the Volta region. And for each of these regions, we had community health officers, community leaders, household heads, NGOs, healthcare administrators, as well as policymakers participating in the study. For our design and procedure, we used a concurrent triangulation mixed methods approach, which involved a survey, in-depth interviews, key informant interviews, focus group discussions, desk review, and participation workshops. For our desk review, we used a guide to identify and collect appropriate literature that outlined the barriers, enablers, and lessons learned, as well as recommendations that has been identified in earlier studies. These also help us to identify gaps in some of these studies. And for the focus group discussions, as well as the key informant interviews, these tools were used to contextualize and also explore the barriers further, as well as enablers for mass LLIN distribution campaigns in other communities. For these qualitative methodologies, we did 14 FGDs. We also conducted KIIs, that's key informant interviews, with policymakers as well as practitioners. There was also a baseline survey. This baseline survey was used as a parameter to help us with the assessment of the effectiveness of our intended co-created intervention. The survey also provided information that was used to determine the content of our participatory workshops. So how did we go about this co-creation? At the co-creation point, we used findings from the desk review, focus group discussions, key informant interviews, and baseline surveys. All the findings were synthesized and grouped according to relevance. We further distilled them, and they were used to form the basis for our participatory workshop guide. Again, at the co-creation stage, we had stakeholders, different stakeholders involved in this: investigators, NGOs, school health education teachers, ANC nurses, disease control officers, and the list goes on and on. The co-creation process involved a participatory learning in action technique, which is a practical adaptive research strategy that enables diverse groups and individuals to learn, work, and act together in a cooperative manner to focus on issues of joint concern, identify challenges, and generate positive responses in a collaborative and democratic manner. As you would see from the images that we have provided, we use different approaches to collect information at this stage. A lot of them were participatory. We use sticky notes so that we allowed each participant so that they can give us their own understanding of the issues. We had a number of people gathered at the table. We made sure that the environment was conducive for responses to be elicited. There were pebbles that were used to indicate people's desire for a particular answer. And also, as you can see in the flip charts. We got to the point that we will list the numbers and the groups of people or categories of people that has been proposed, and then we would rank them. Findings from the participation workshop were further synthesized, and it helped us with the cooperated intervention, which is our results. At this stage, as we synthesize the information, we realized that the establishment of a community health advocacy team, CHAT in short, would be necessary in efforts aimed at transitioning the LLIN distribution campaigns in communities. You would see from this diagram, we have tried to synthesize all the components into this diagram. For instance, the question is, who forms the CHAT? Through the co-creation process, we were told that the list of people that can help to engage communities for them to start using the LLINs would include the CHOs, religious leaders, assemblymen and women, community information center officers, municipal volunteers, and the list goes on. At that point, they also told us that we would need to motivate them both tangibly and intangibly. There are roles that they can play, and we believe that these roles will be centered around the SBC, that's the social mobilization, social behavioral change communication campaign, and that is what we would embed this in. Apart from community mobilization, there was also the need for capacity building. Whoever we identified to be part of the CHAT group would have to be provided some skills and competencies. And these are supposed to cover the areas of the LLIN use and maintenance, communication skills, leadership skills, as well as ability to map communities. They could be meeting quarterly, and this is what we are actually drafted as our intervention. Would like to mention at this point in time, by way of conclusion, that the use of the chat will be instrumental in community and social mobilization, as well as capacity building that will focus on social behavior change communication. We are still in the process of assessing the acceptability and feasibility of the chat intervention with all stakeholders. What we are about to do is to go back into these communities, again, identify stakeholders, share our intervention with them, and also find out whether this will be practical to engage in, whether it will be burdensome for them to do, what are the opportunity costs regarding this intervention. And we are hoping that by asking these questions, we'll have enough feedback on whether this is acceptable and feasible to be conducted or implemented within these communities. We also want to mention at this point that we will be doing the assessment of the effectiveness of the chat intervention, but this will be done at a later time. We want to share this reference with you, very useful. You can go ahead and consider that. Thank you very much for spending time with us.